Yeah, now.
No? Yeah, started.
So, hi everyone, good evening. So, this is a series of masterclass on Mullerian anomalies and fertility. So, in our routine practice, we come across this combination of Mullerian anomalies and fertility commonly, but we have found challenges in terms of like evaluation, and also because the evaluation is so confusing and many people kind of get lost in the evaluation, so the treatment also becomes a little skewed in terms of what is appropriate and what is not. So these sessions will throw light on the practical aspects of diagnosing the Mullerian anomalies, the ones which needs treatment, the one which doesn't need treatment, and also like what are the methods which we can use to evaluate them without actually making it a costly affair, and the patient not to be like running from pillar to post to even just have a diagnosis. So over to you. You can start.
Okay, I'll just share the screen.
Stop laughing.
Oh God, it was so comedy. Okay. So, so I think when we try and talk of fertility with Mullerian anomalies, okay, see, I think as Dr. Shilpa has decided, we will be taking it through a few sessions. So let's say maybe 4 or 5 sessions. But what is important for everybody to understand is just one quick line on how do we judge these Mullerian anomalies. Okay, so paramesonephric duct on both the sides is going to come down. Okay, and this entire part is going to give rise to the formation of uterus. Of course, there will be two of them because there are two ducts. Okay, and they will have their individual fallopian tubes. All right. They will have their individual fallopian tubes here, and simultaneously there will be two such vaginas like this. When these guys are descending downstairs from below, from the cloacal membrane, okay, they are going to go to the cloacal membrane and then they are going to fuse with the cloacal membrane. Okay, and this cloacal membrane which is present here will then cause disintegration of this entire tract and canalization of this entire tract. So this canalization which occurs is going to be a differential canalization. All right, some parts will get canalized first, some parts will get canalized later, some parts will just not get canalized, some parts will just not be formed, some will just not descend, and some will be absent. Okay, which is what gives rise to Mullerian anomalies. So first thing, please remember, all these guys are actually anatomical defects. Okay, they are congenital. Majority nahi, all of them are congenital defects. So that means there is going to be no medical management. All right, you can't give a tablet which is going to go and dissolve the septum. You can't give anybody a tablet to go and make the bicornuate uterus unicornuate. All these types of things won't practically be happening. But as fertility specialist, you need to remember this line. Okay, I will just give you this wonderful line about Mullerian anomalies, which will probably help you the most. Okay, as long as it is a complete absence, okay, in that situation, it is the most difficult to treat. All right, anything which is completely absent, it is most difficult to treat. So whenever there is a complete MRKH, that means uterus is absent, vagina is absent. Okay, that is very, very difficult to treat. If the uterus is present, vagina is absent, that is also difficult to treat. If the vagina is present and uterus is absent, that is also difficult to treat. If the uterus and vagina are both absent, that is extremely difficult to treat, because those types of things you have to redo artificially. And whenever you redo anything artificially, there is no anatomical correlation. And because there is no anatomical correlation, the fertility outcomes are very, very poor when things are absent. Okay, just remember that. As far as things being present is concerned, okay, and if the things are present in an abnormal manner, for example, if the uterus is, let's say, bicornuate, unicornuate, didelphys, or any such combinations, Robert's uterus. Okay, the important thing is uterus is present. Okay, this word is important. Same thing comes in the vagina. When the vagina is present, only if the vagina is present, okay, you can have transverse vaginal septum, you can have longitudinal vaginal septum. All right, here you can have a septate uterus. Okay, all these places where the organ is present, uterus present, vagina present, but there is an anomaly, usually these are going to be easy to treat. Okay, these are going to be easy to treat as far as the Mullerian anomalies is concerned. This is easy to treat because then it comes down, actually the ease comes down to the expertise of the guy who is treating it. The ease is not based on this, the feeling of expertise. It is actually going to be upon the expertise of the guy who is actually treating this. Now whenever I am talking of vagina present, uterus present, all right, the guys which are going to have the best fertility outcomes are the guys in whom the Mullerian anomalies are the least. Okay, so best outcomes are with least amount of anomalies. So what do I mean by that? Basically, I will just show you and you will understand everything in a single diagram. Okay, just see this now. And we have all seen this, huh? Because we all know this, though we don't try to correlate, but we all know this. Okay, but in this diagram you will be like, अरे ये सच बोल रहा है. This is the uterus. If the cavity is T-shaped cavity, we hardly treat. Correct? If the cavity is a normal cavity, but with a slight arcuation, we hardly have to treat. Correct? Simultaneously, if there is a small septum, all we have to do is we have to use scissors and we have to just cut it open. Just cut it open. As the quantification of this anomaly keeps on increasing. Now, if the septum becomes big, we have situations where people say, I will do a two-stage surgery instead of a one-stage surgery. There will be some amount of septum which will become a residual septum. Some people are still debating between resection of the septum versus removal of the complete septum. Correct? Many such debates will come. If this septum is extending into the cervical canal, myself and Shilpa madam have treated these patients in Bangalore, where it is, complete septum is there till the cervical canal. Then people are confused whether to cut the cervical septum or not. Will it cause any form of cervical incompetence or not? All these things we are very, very worried about, because the once there is a development of a Mullerian anomaly, please try and understand. Okay, after you understand this concept, please try and understand in this concept itself for Mullerian anomalies that what is going to happen is God has gifted the uterus to be something like this. See, when God made this uterus, no, God did not really know that Mullerian anomalies will be such a big challenge. God just thought that some people I will give Mullerian anomaly, so that probably if the anomaly is so severe, they may not be able to conceive. All right. When you look at the microstructure of these fibers which are present here, muscle fibers, these are the muscle fibers, these are the structures in which the microstructure of the fibers is. Okay, the uterine musculature. All these guys come close to the internal os, and when they come close to the internal os, they have formed one thick little region, and then they form the cervical musculature, as a result of which the cervical musculature feels very, very different as compared to the uterine musculature. As a result of this, the uterine diseases of the body are different compared to the diseases of the cervix. Understanding? And as a result of this, we know that due to these differential muscular pattern in the uterus. Okay, this is the final thing which you should remember. Any anomaly which involves the muscle, any anomaly which involves the muscle, okay, will affect the cervical integrity. Because for the cervix to be integral, this type of muscle which is to be present is supposed to be important. Which is why in uterine didelphys, you do not need to have a cervical stitch or a cervical encerclage. But if it is a bicornuate uterus, if it is a unicornuate uterus, if it is a septum in the cervix, okay, in all that situation, your cervical encerclage is mandatory. Simultaneously, if it is just a septate uterus, let's say if it is just a septum in the uterus, which is not affecting the muscle, same manner, just like didelphys uterus, the cervical stitch may or may not be necessary in that entire situation. Now, if you understand the Mullerian anomalies and if you classify the Mullerian anomalies in this manner, you will start to realize, as I told you, that the fertility outcomes or the outcomes of IVF are going to be improving absolutely drastically the minute the anomaly becomes smaller. What we have to understand as doctors when we do a diagnosing of these Mullerian anomalies, and that is 3D ultrasound of the pelvis, is something which is absolutely mandatory. And please remember, any Mullerian anomaly which is non-obstructive, okay, will have no pain associated with that, will have no endometriosis associated with that, and will have no renal anomalies associated with that. Okay, which is why non-obstructive anomalies are the ones which are going to have the best fertility outcomes as far as having natural conception is concerned. The minute you are trying to deal with an obstructive pathology, the problem with obstructive pathologies is usually these are the patients who will end up with IVF because majority of them will end up having something called as a hematosalpinx, which will compromise the tubal anatomy drastically. Okay. And finally, remember one thing, a lot of Mullerian anomalies will also be associated with low AMH. I really don't know why it happens, but you must remember that a lot of these Mullerian anomalies are associated with low AMH. In this entire session of the last 15 minutes, I just wanted to give this as an overview to everybody, which is the part one. That if you look at Mullerian anomalies in this manner, okay, very simple classification. Is the organ absent or present? Is the anomaly obstructive or non-obstructive? Is the anomaly related to uterine muscle or not related to uterine muscle? Okay. If in case you are able to grade the anomalies in just these 3 points, you will be able to immediately classify fertility outcomes for these patients like this very, very, very rapidly. And once you are able to classify the fertility outcomes for the patients, you know which patient to go for IUI, which patient to go for natural intercourse, which patient to go for IVF directly. In that also, the most important thing is obstructive anomalies and non-obstructive anomalies. Trust me, nothing beyond this. So just to give you an example, a lot of people say this and they ask me very commonly because we end up doing a lot of that we have a Robert uterus. A Robert uterus is not an obstructive anomaly, okay, because the menstrual blood is coming out. You're absolutely wrong. Robert uterus is classified as an obstructive anatomy, obstructive anomaly, because a part of the blood is still inside as a hematosalpinx, correct? As a hematometra. Same thing is with Ovira syndrome. Hematocolpos is present. That hematocolpos itself is an obstruction. The minute there is an obstructive anomaly, remember majority of these patients will end up with IVF. Okay. The minute it is a non-obstructive anomaly, bicornuate uterus, complete septum, correct? Complete septum, people become pregnant naturally. There is nothing to the fallopian tubes, correct? Large septate uterus, arcuate uterus, T-shaped uterus, no obstruction anywhere. Okay. Same thing happens with transverse vaginal septum. There is a big difference between having a transverse vaginal septum and having a mid-vaginal atresia. Mid-vaginal atresia and transverse vaginal septum are different things. I think Shilpa madam herself has seen so many of mid-vaginal atresias after we have started doing surgeries at her place, that you have to really feel it and see the difference to see the difference. Okay. And one final thing before I conclude: the sooner you operate a Mullerian anomaly, the better is the outcome. Just remember that. Do not fall prey for all that nonsense. Do it when she is going to get married. If she gets married at 48, you will do it at 47 or what? Okay. All these types of things you should not keep in mind. Mullerian anomalies are to be corrected once diagnosed. Okay. Once you diagnose an anomaly, go ahead and do the correction what is required. There is no time interval, there is no waiting period. That is a beautiful way to hide your competence from the patients. Okay, no, we will do it when you are 27. Okay, that is a way to hide your competence. You will obviously get some of the patients who are totally fools, who will end up to listening to all these things. Okay, but majority of the patients will not fall prey for all these things, because even they are little intelligent. So keep that in mind. In the part 2 and part 2 of this class, we will try to cover all the non-obstructive anomalies and how we will do the fertility protocols for them. And in the part 3 of this class, we will cover all the obstructive anomalies and how can we optimize the fertility in them. Okay. And part 4, if in the case we go through, then we will go through the fertility outcomes which we need to do for atresias. Okay, cervical atresia, vaginal atresia. Okay, see, yeah, same thing is with MRKH. Whomsoever has asked that question, I think you are a first timer to this masterclass. If you have seen MRKH, we have corrected MRKH at 15 and 16 years with Shilpa madam at her place in Bangalore. And it is not one anomaly. We would have done more than 20, 30 anomalies already at her place. And everybody has a beautiful outcome. In fact, when we went to the last visit at Shilpa madam, there was a young girl, maybe 23, 24 years old, who has such a beautiful vaginal length. She's following up very nicely, and she has such a beautiful vaginal length that you cannot imagine. And she has no plans of marriage, at least for the time being. Okay, so don't fall for all those teachings which are outdated teachings. Okay, so with that I conclude. Thank you.
Can I ask, or are we done? Just two questions.
Ask.
Okay, so obstructive anomalies are more commonly diagnosed in early age, like because now the age at menarche is 11, 12, or sometimes even 10. So we are seeing more and more younger girls coming in for these, the diagnosis, because they have pain, and we see that there is huge hematometra, hematocorpus, and even hematosolvings. Like last time we had to remove both the fallopian tubes for a young girl at the age of 30. Uh, what is your take, or what message would you like to give all the primary gynecologists when it comes to these young girls with obstructive lesions who come into their OPD with pain?
One has to evaluate, one has to operate if it is a Mullerian anomaly. One cannot sit on it. Okay. Look, it is somebody else's daughter. Okay. Treat that child with respect. Don't send it, let's say, to us. Send it to somebody whom you think is a specialist. Okay. But at least get the correction done. Because, see, we are not in a position to give any comments about the repairs because we are a referral unit. So we end up we mostly, like Shilpa madam knows, we end up repairing the repairs which have been done by people who think they can repair. Understanding? At one stage in life, even we were like that. We used to think we can repair everything. Till you actually dive deep into this, you will realize. You ask Shilpa madam, she will tell you, every time I come to her place, every 6 months, I will have a little change in technique in that Mullerian anomaly. Very little, but it will be present. And that little change will cause big effects. Long vagina, beautiful breadth of the vagina, less pain, introitus is big, perineum is dilated. If you don't invest your time and energy into it, see, majority of the people end up doing one vaginoplasty in a year. They don't do one vaginoplasty in every 3 days like how we are operating. So there is a huge difference in experience. Okay. So it has to be calibrated. These type of outreach programs which we do will reach more patients than doctors, which is why patients will only end up coming to specialists and getting themselves corrected very nicely, is what I think.
So many people say that, like, MRI will give, I think, accurate diagnosis, but we have seen that it is not possible.
Yeah.
Where on table there are so many surprises, like many a times until
MRI is really dependent on who reads it in these Mullerian anomalies. Okay. Which is why I have sort of told many times that you should do a per rectal examination in Mullerian anomalies and you should do an ultrasound. These two things are very, very good. And never forget to look at the kidneys.
Hmm, hmm, hmm. So do you think, like, I mean, though ovarian origin embryologically is different, so ectopic ovary is something which I read in the literature are commonly associated with unicornuate uterus and all. So, but we see this ectopic ovaries, like, I mean, they are very highly placed and they are not in their normal position, even in MRKH or even in cases where there are just those rudimentary horns and all that. So, is that relevant? I mean, since, like, in
Yeah. See, whenever we are trying to talk of disorders of differential canalization, okay, these are also related to disorders of migration, correct? Because probably they are migrating down through the same pathway, and there must be something wrong in the circuit of that pathway, that there is some differential canalization. So to it is normal. Why don't we see that when we are operating Mullerian anomalies, ovaries are placed close to the pelvic brim? We see it so commonly. It is not abnormal also. Okay. We always think, "Arey, ठीक था," types, Probably it is due to a shortened IP ligament. Probably it is because of the renal angle did not really migrate as high as it should have. Like, it's so variable. But these are disorders of migration and canalization, and they will go hand in hand.
Yeah, so like you classified as, like, clear cut, like obstructive, non-obstructive, and canalization problems, what you said. So the classical classification is about, like, naming it as MRKH, unicornuate, bicornuate, diadelphys, and such. So I don't see that, even like two, three patients, if we see with the same diagnosis, they're so different on table.
Exactly.
So the conventional classification that we have and the repairs that we have, I don't think each patient, like one, this thing fits every, one surgery fits all. So everything.
See, which is why I think probably out of experience, we have classified it into very simple things. Is the organ absent or present? If it is present, is the anomaly obstructive or non-obstructive? Correct. And based on that, we want to treat. Okay. If the anomaly is just obstructive, then we know that we don't have to, then we know that some amount of muscular correction will be involved. If the anomaly is non-obstructive, then we know that muscular reconstruction is not going to be involved. If we know that the organ is absent, then we know that no matter what we do, we can't reach to the original musculature. Correct. Even if we put a sigmoid vagina inside, it is not the original musculature of the vagina. You can't really have a normal delivery through a sigmoid vagina. That is never going to happen. Correct, no? So, one has to accept the superiority of nature in these diseases.
So competency, level of competency in laparoscopic surgeries that we talk about, like, I mean, there is a basic level, then there is advanced level, and there is advanced level. So in which of these categories that these Mullerian anomalies fall, like the skill sets, I mean, for a laparoscopic surgeon? I know endometriosis surgery is something which is highly advanced because of the adjacent organs involved. In Mullerian anomalies, yes, I mean, there is not much of adjacent organ involvement, But there is a lot of change in the anatomy, lot of variables that are there in each case. So, what do you think based on your so much of experience in dealing with this?
See, I think if it is a reconstruction, then you require a lot of expertise. If it is just a resection, then probably a basic level expertise should be okay. But if it is any form of reconstruction, which is predominantly when the organ is absent or when the organ is having an obstructive anomaly, okay, then the amount of reconstruction which you require to do a genuine reconstruction requires your expertise of understanding the anomaly in that case on table. Okay, how much peritoneum can you pull? How much rectum can you pull? How much can you not pull? What will be non-functional? What will be functional? How much perineum laxity is present? How much is the rigidity of the perineum? Correct? So many factors. So many. Correct. And one has to judge or, do something based on that.
So, in your experience, what is the commonest Mullerian anomaly that you see? I know you're a referral unit. For you, the commonest will be very different than what it is for us as general gynecologists.
I mean, I see vaginoplasty redos as the commonest.
For us, it is septate uterus, which is most commonest, though it will be written as diadelphys,
Yeah,
bicornuate.
bicornuate. Correct.
So septate is the commonest that we all see, and I think that should have the high index of suspicion when a gynecologist sees a Mullerian anomaly. So for you, redo vaginoplasty, yeah, I agree. I agree. I mean, I have seen it happening, so I think I should agree. I mean, there's no point in arguing. Okay. Yeah. Thank you so much.